I'm here to talk to you today about acute coronary syndromes, and we're going to go over the essential concepts. It is a true pleasure to be here, and thank you so much for joining us. So our goals in evaluating someone who's coming in with ACS is, of course, here. So ECG within 10 minutes, as quick as possible. Really, the biggest goal is we want to identify patients who are going to benefit from PCI or thrombolytics, who are going to benefit from reperfusion therapy. That's the big goal, and that's going to be the theme that we use in talking about the different concepts today, because some of the terminology is changing, and I'm going to address that as well. Of course, we want to initiate medical therapy for these patients who are demonstrating ischemia, and we want to use our risk assessment tools, things like the heart score, to try and identify and risk stratify our patients. Those are our sort of overarching goals when it comes to people coming in with chest pain or something we're concerned might be ACS. In this talk, we're going to identify STEMI and STEMI equivalent ECGs. We're going to talk about the medical management of ACS. This is absolutely bread and butter stuff that we all need to know. And then we're going to, again, talk about risk assessment for patients who come in with low-risk chest pain. There are some new updated guidelines. They came out in 2021 from the JACC, the JCC and the ACC, all these different letters, the cardiology groups that have some recommendations, changes in how we might address patients who are coming in with low-risk chest pain, and I'm going to talk about those. So the really important part of this slide, I think, is actually on the right side, where we're looking at the heart and the way that the EKG leads match up with the location of the heart. This EKG here at the bottom is a nice corollary. So I think if you're going to pay attention to anything on this slide, just spend a little time looking at that. Of course, this is how the EKG matches up to the location of the heart. You can see that leads 2, 3 AVF. That correlates with an inferior MI because, again, that's the inferior aspect of the heart. And you can see that on the EKG, an inferior MI leads 2, 3 AVF. That matches up with the right coronary artery. So that's sort of how you can use that. And then septal, when we have a septal or an anterior MI, we're talking about really leads V1, V2, V3, V4, kind of septal anterior, and that correlates with the left anterior descending, going straight down the front of the heart. That's the anterior part of the heart, and also the septum. We have the lateral leads V5, V6, leads 1, and AVL in blue on the EKG. And again, correlates with that left circumflex, just coming off laterally around the heart. And so that's why we see the changes that we do. So I really like this. If you haven't seen it before, take a little time to get familiar with it. Let's talk about ACS. What is it traditionally? When we have said ACS in the past, it's really 3 things. It is STEMI, NSTEMI, and unstable angina. If you have any one of those 3 things, you can say that you have ACS. And this is the traditional terminology that we have used. Traditionally, STEMI on an EKG, of course, is ST elevation. You can see it on the EKG. It's in a predictable pattern, and it's in contiguous leads. We're going to talk about that. You also have troponin elevation. So the definition of STEMI is the EKG changes and troponin elevation. You have to have those two things to have a STEMI. It suggests full wall thickness. Again, this is the traditional idea behind a STEMI. We say if someone's having a STEMI, they have these EKG changes, they have a positive troponin, we're thinking that they probably have full wall thickness involvement of their heart. When we talk about an NSTEMI, traditionally, to have an NSTEMI, you have symptoms suggestive of ischemia, you have troponin elevation, but importantly, you do not have ST elevation on your EKG. Now, you can have ischemic changes, you can have T-wave inversions, you can have ST depressions, but you can't have an ST elevation on your EKG. So that's, again, the definition of an NSTEMI. And again, traditionally, what we thought of when we diagnosed someone with an NSTEMI is that this was maybe partial wall thickness involvement. Now, I want to just pause here and talk a little bit of a change. We're having a change in terminology and the way that we think about people coming in with acute coronary syndrome. Has anyone heard of the OMI manifesto? Occlusion, myocardial infarction. That's what OMI stands for. This is a relatively new concept. I think 2018 is probably when we first started talking about it. And the idea behind this is that if we say someone has a STEMI and they need to go for PCI, there are a group of patients who we've diagnosed with a STEMI, they're going for percutaneous intervention, we've taken them to cath, and they have a clean cath. There's nothing there. But more importantly, and this is what we really worry about, is we diagnose someone with an NSTEMI. We say they don't meet criteria for STEMI, and we're not going to take them to get emergent intervention. We're going to treat them medically and maybe eventually take them for cath. Studies have shown that we're missing about 40% of patients who may benefit from PCI. So there is this group of patients who don't meet criteria for STEMI. They technically fall under this NSTEMI criteria, but they are having an occlusive myocardial infarction. They have an area that needs reperfusion. And so the concept of OMI, if you start to see it or if you start to hear it, it's really moving away from these very rigid definitions of if someone has a STEMI, we're really worried, we're taking them to the cath lab. If someone has an NSTEMI, we're concerned, they get admitted, but we're not emergently taking them to the cath lab. We're moving away from that to trying to identify patients who would benefit from reperfusion therapy. And we're using a number of different factors to do that. Of course, we're looking at the EKG, but we're not just worried about patients with STEMI. We're worried about STEMI equivalents. We're worried about ischemic changes with a clinical picture that's concerning. So looking clinically at the patient, and then of course labs and other biomarkers. So really taking a more holistic approach, less rigid definitions, and trying our best to identify patients who would benefit from reperfusion. Because again, with these rigid definitions, we're missing people. And so that's the way we're headed. Unstable angina. What is unstable angina? So really, this is all symptom-based. There's no troponin elevation. These patients just have really concerning symptoms. So they have a change in their angina where they used to say, hey, yeah, I could get this really predictable chest pain anytime I did this one thing. But recently, I've been getting new and different chest pain with different activities. Or now at rest, I'm getting that chest pain. I used to only get it when I walked up that hill, but now I'm at rest and I get that chest pain. That's unstable angina. So when it comes to the clinical presentation of someone coming in, they've got chest pain, are we concerned, are we not? How are we gonna flesh this out? This is one of the 2021 updates from the JACC, and they basically tried to help us decipher who needs, who has a cardiac etiology for their chest pain. Like, is this person having a cardiac event and they need intervention? We all know that is very challenging. It can be hard. Okay, if they have a positive troponin, boom, slam dunk. But what about these people who look really good, they're complaining of chest pain, and you're just not totally convinced, you're not totally sure if this is cardiac or not. So here's a few things. These are really the key points out of a huge document. I think this thing is like 50 pages. Don't waste your time reading the entire thing. These are really a few of the things you need to know. First of all, they're changing the concept of how we define chest pain. They're saying we should no longer be saying chest pain. It's not really a good name. We should be saying chest discomfort because, again, studies have shown over and over again that patients, it doesn't matter how they describe their pain. They could say it's sharp. They could say it's pressure. They could say it's tightness, and it doesn't correlate with whether or not it is a cardiac cause. Now, there are a few words in this document. They put a few words out saying you should really worry about this, and they say pain, pressure, tightness, if they're having discomfort in the chest, in the shoulders, in the arms, not just the left arm. Both arms, either arm, going to the neck, the back, the jaw. If they have some shortness of breath, even if they have some fatigue, you should be concerned. But the big point here is that you cannot hang your hat on the way that patients describe chest pain. Studies have shown over and over again, it does not matter what words they use to describe it, it doesn't correlate with whether or not that is slam dunk cardiac or not cardiac. So that's the big takeaway. What about accompanying symptoms? So the other thing that they note here is that yes, chest pain is the dominant and most frequent symptom for both men and women. But importantly, women are more likely than men to present with accompanying symptoms, such as shortness of breath. So whereas a man might present in that very typical way that we think of, that we read about all the time, women may have some other symptoms going along with it. And we just need to clue in that this still could be cardiac. And just because they're, having some nausea and shortness of breath with it, it doesn't mean that they have an upper respiratory infection or something else. This absolutely, it could still be cardiac. Women may present differently than men. And this is a trend, again, that's happening in medicine. We're recognizing that women are often overlooked and undertreated because they present differently. They present differently than the sort of classic teaching. And so we're trying to, cover those bases and recognize that women also, they present differently and we need to be aware of that. Symptoms may be gone prior to ED arrival. So just because the symptoms are gone when you see that patient doesn't mean that they don't have a serious cardiac problem that is going to need intervention. And then finally, the terms are changing. They have changed their terminology. So in the past, we used to say, this is atypical chest pain. I don't think that this is cardiac. You're having atypical chest pain. They say that they no longer want us to use that term. They would prefer that we use the terms cardiac, possible cardiac, and non-cardiac. Now, here's the thing. I do think that it's useful to get rid of atypical chest pain. Like, what is that? What does that even mean? That's not very specific. It's not very helpful. It is something we used to use with women a lot of times. We would say this, it's a woman presenting with atypical chest pain. It's not useful. I think it's good to get rid of that term. But it's not helpful to suddenly say that everyone has to identify that this is cardiac or non-cardiac, because we all know that you cannot say something is non-cardiac unless that person goes to the cath lab. If they go to the cath lab and they have a completely clean cath, then you can say it's non-cardiac. But until that point, you cannot say that this is non-cardiac. There's no way to know, and that's a dangerous thing to fall into. So you could just say this is low-risk chest pain. That's a much safer term to use. I think that this is low-risk chest pain. All right, let's get into it. So let's talk about STEMI. What are the EKG criteria for saying this person has a STEMI, we are activating the cath lab? It's pretty straightforward. Basically, it is a new ST elevation. Hopefully we have an old EKG to compare to. We don't always have that, but a new ST elevation, it's at the J point is where you're measuring it. And of course, that's relative to the PQ junction, the baseline. It has to be in 2 contiguous leads in sort of an electrical distribution, right? Those distributions we already talked about. Inferior, 2-3 AVF. Anterior, V2, V3. It's got to be in a distribution, and it's greater than 1 millimeter. ST elevation, greater than 1 millimeter, contiguous leads. Boom, slam dunk, that's a STEMI. The only exception here is leads V2, V3, so that anterior MI needs to be a bit higher. And so in men who are greater than 40, greater than or equal to 40, we need 2 millimeters. In men who are less than 40, we need 2.5 millimeters. And in women, we need 1.5 millimeters. That's the only other thing you need to remember. When we see someone with ACS, you all know how to do this initial assessment. IV, get them on a monitor, we get a chest x-ray, get some labs. What's that chest x-ray for? Is that going to help us diagnose that this person needs to go to the cath lab? No. That chest x-ray is really to help rule out other causes of their chest pain. You're looking for things that could explain why they're here, aside from needing to go to the cath lab. For example, do they have congestive heart failure? Are they showing us that they have signs of a dissection, big widened mediastinum? Do they have a pneumothorax? That's what we're looking for on that chest x-ray. If they have symptoms consistent with ACS and you don't think they're having a dissection or bleeding, then you're going to go ahead and give aspirin, and that person needs PCI, emergent reperfusion. They need to go to the cath lab or they need to get thrombolytics. Let's talk some more about those meds. So of course, aspirin. That has been shown to have a mortality benefit, and the number needed to treat, I think, is 42. So that is something you're definitely going to do for your patients. Aspirin, aspirin, aspirin. You're going to start them on unfractionated heparin, usually, especially if they're going to go to the cath lab. And then in discussion with your cardiology team, of course, some kind of other antiplatelet. So that dual antiplatelet is aspirin plus, one of these P2Y12 inhibitors, clopidogrel or ticagrelor, which is always a hard one to say, speaking with your cardiologist. And then plus or minus nitroglycerin, depending on their blood pressure, what distribution this STEMI is in, and if their blood pressure can handle it. So again, right here, dual antiplatelet therapy, that is aspirin plus. So just what we talked about, either the Plavix or the ticagrelor. It could also mean a glycoprotein 2B3A inhibitor, which are listed here. Don't make me try and say those. That's another option. This is all in discussion with sort of cardiology and also what your institution uses. Sometimes we give all three. What about this old regimen, MONA or MONA-B? I don't know if anyone's ever heard of that. When I was in med school, this is what we were taught. Yeah, if someone's coming in and they're having a cardiac problem, they're having a STEMI, go for MONA-B, morphine, oxygen, nitroglycerin, aspirin, beta blocker. This is fallen out of favor. A lot of these are not good or used anymore for a patient who is having acute MI. In fact, the two that are useful are nitroglycerin and aspirin, and nitroglycerin comes with that caveat that we just talked about. So let's talk a little bit about it. Morphine. There's been a number of studies about morphine, and the big concern is maybe it has bad for mortality is one of the big concerns. And the other big concern that people are pretty convinced about is that the antiplatelet medicines are not going to work as well if you use morphine. And so that is all listed here. There's been lots of different studies, kind of the stuff about whether or not this may affect overall mortality in a negative way has been debated. Some of the evidence is not quite as strong there, but there is very good evidence that it may delay the GI uptake of the antiplatelets or may inhibit those antiplatelet drugs. And so generally, we are not reaching for morphine for these patients. If you cannot get their pain under control, you've tried other things, usually nitroglycerin is first line, you've tried other things, you can't get their pain under control, then yes, you could reach for morphine or fentanyl to make the patient more comfortable, but just know that it comes with these caveats. What about oxygen? So this is so classic. We have these patients who come in from EMS, they're in extremis, looks like they're having a STEMI or they're having chest pain, and they've got nasal cannula on. And, I'll say to the team, were they desatting? And the answer usually is no, it's just on there for comfort. Don't fall into that trap. That is a mistake because oxygen can be harmful for these patients. All these studies have been done. Increased overall mortality, increased infarct size, recurrent MI. You only should place oxygen on these patients if they need it, if their oxygen saturation is low, if they are hypoxic. Otherwise, no, take it off. Nitrates. So again, nitroglycerin. This is a beautiful drug for, especially if that person is coming in with pulmonary edema, they've had an MI, they're in flash pulmonary edema. I love nitroglycerin, especially when the blood pressure can handle it. If they're, of course, very hypertensive, they have refractory chest pain, nitroglycerin is great. A couple of things, IV and sublingual are best. The transdermal is always on my patients. It's really good to just wipe that off. I mean, you cannot measure how much they're getting. Is it an inch? Is it an inch and a half? How much are they getting? How quickly is it working? So just immediately wipe that off. You want to be able to titrate this. Things change very quickly in these patients. So IV nitroglycerin is a very quick on and off. It doesn't last very long. It's much, much safer. While you're waiting for the nurses to set up that drip, you can give them some sublingual. And I always like to do that because I like to see how they respond to it. You give them a little sublingual and you see what happens with the blood pressure. If they've handled that, then you can throw them on the drip. They're going to be just fine. Of course, you're going to avoid using nitroglycerin in patients who are taking sildenafil because they can get refractory hypotension. Remember that. So it's a sensitive question, but an important question to ask your patients. Avoid it in patients who are going to get alteplase because it can increase the metabolism of alteplase and then make it less effective. What about aspirin? This I already told you. We're going to give aspirin. If there's no concern for bleeding, give aspirin. It has a small number needed to treat to have a good mortality benefit. What about beta blockers? The story on this is that they can be dangerous. You definitely want to avoid them in patients who are at risk for cardiogenic shock. And if patients are really, really sick coming in with a STEMI, they are generally at risk for cardiogenic shock. Anyone who has CHF or low cardiac output, not good to start them on beta blockers in the ED. I really never grab a beta blocker in someone coming in with a STEMI in the ED. It's something that can be started later once they're a little more stable with the cardiology team. What about heparin? Yes, we're going to use heparin, give it as a bolus, and then start the infusion. There's a procedural benefit for patients who are going for PCI. It can help to prevent thrombosis, and it can be a bridge to definitive therapy for people who are waiting a little bit longer to get to the cath lab. Statins, those again, I do not usually grab a statin in the ED. That's something that can be started upstairs within the 24-hour period. Let's talk a little bit about troponins. So troponins are, of course, INT are exclusive to myocardial cells, but they don't just rise when you're having an MI. We know this. There's a lot of different reasons that you can have a troponin, and we call this, type 1 and type 2 end STEMI. Is this demand or is this primary cardiac? What exactly is going on with the patient? So usually we use the terminology, this is a type 1 end STEMI if someone has a rise in their troponin, and we really think it's because they're having ischemia, this person is having a cardiac reason for it. Sometimes we use the term a type 2 end STEMI, you may have heard that, when we think that it's secondary to something else, like an elderly person who's septic, really, really septic, their whole body's under stress. A lot of times they will bump a troponin, and it doesn't necessarily mean that they need to be going to the cath lab. This is the sort of rise. They have a very predictable rise and fall. Rise within 3 to 6 hours, peak at 12 to 24. It should normalize in about 7 days. At our shop, we're not using the ultra-high sensitivity troponins, but I will say that in the latest guidelines from 2021, the ACC guidelines that I keep referring to, they do prefer high sensitivity troponins. But we're not using them at our shop. These are all, a bunch of reasons that you can get a rise in your troponin that have nothing to do with having an MI. I think we've all seen this, especially patients who are really sick with sepsis, other sort of insults to their system. All right, what is the treatment? What are we going to do for these patients? Remember, the clock is ticking. Time is heart. Just like for stroke, where time is brain, when it comes to an MI, time is heart. And our goal is to get these patients to the cath lab so that they can get PCI within 90 minutes of arrival. As soon as they arrive, you've got 90 minutes. That's your door to balloon time. And if you're at a non-PCI facility, you need to transfer that patient. You get a little extra time. You have 120 minutes. If you're going to give thrombolytic treatment, you have 30 minutes from the time that they meet you, from the time of provider meeting the patient. You have 30 minutes. That's the door to needle time. So who should get PCI? Who should go to the cath lab? These are really the sort of formal definitions. And I would again say, use your clinical judgment here, because there are going to be patients who don't necessarily meet this criteria, who have ongoing symptoms, who maybe have a concerning EKG, and you're going to need to push for them to get at least a cardiologist, someone to look at them, and maybe even to go to the cath lab. That's the whole concept between moving towards this occlusion MI, idea that we're trying to identify patients in a more holistic way. But the formal definition is here. So STEMI, anyone coming in with a STEMI and having ischemic symptoms, or if they have ongoing ischemia, if they've been having pain for a while, they're having ongoing discomfort, those patients need to go. Patients who do not have a STEMI, so they have an end STEMI, so positive troponin, but no STEMI on their EKG, but they're having hemodynamic instability. So these patients are in shock, they're in pulmonary edema, they're in some, they're in having runs of VFib or something like that. Runs of VTAC really would be probably more survivable there. So, they're having some arrhythmia. That is someone who you should push for to go to the cath lab. And then again, an end STEMI with refractory ischemia. So they're having ongoing symptoms of angina. They're not looking good. Their EKG is not showing a STEMI, but they don't look good, and you're very concerned about them. And maybe they have some concerning findings on their EKG. These patients, you should push to go to the cath lab. And then what about thrombolytics? We talked about door to needle time. So we're going to use thrombolytics if it's going to be more than that 90 to 120 minutes from the first medical contact to going to cath lab. So if there's a delay, they can't get to the cath lab in that 90 minutes or that 120 minutes, then consider thrombolytics. If they have a large area of myocardium that's at risk, if their EKG shows that it's a very acute insult, where they're still having persistent ST elevation, and it's going to be more than 90 minutes. If they don't meet that timeline where they can get to PCI, then you should consider thrombolytics if you're not going to be able to meet that timeline. Of course, you need to review the contraindications before you give thrombolytics, and there are a lot of them. I often have to look these up. The options for thrombolytics include tenecteplase or alteplase. Tenecteplase is much easier dosing, and then after that patient gets thrombolytics, they do need to be transferred to a PCI-capable facility. Sometimes they still need to get PCI even after they've gotten the thrombolytics. This is just showing the sequence of an evolving MI, sort of how you get those hyperacute T waves. You may have the ST elevation then. You can get a little Q wave, a little Qing out. The T wave inverts, and then how it looks when you get reperfusion with those very deep inverted T waves. We're going to start talking now about specific EKG findings of STEMI. This is how the EKG leads match with the anatomic distribution. I also love this slide. So you can see there, 2, 3 AVF, inferior. They're down at the bottom. That's an inferior MI. That's how those leads match up. Right across the front, those precordial leads, those are your anterior leads, your anterior MI. Your lateral leads, V5, V6, where the left circumflex comes around laterally. And then, and also one in AVL. You can see those are part of the lateral leads there. And you can see AVR way off in the distance, doing its own thing. It's like the complete reverse of everything else. And that is why when you look at the EKG, AVR is always so weird. It's doing its own thing because it's the electrical opposite of all these other guys. So a nice coronary anatomy picture here. So if you just kind of want to think about what coronary arteries being affected with what kind of STEMI, inferior or anterior, here's the anatomy, and here's the coronary artery that's being involved, and again, how it correlates to your EKG. So this is a very normal EKG. It's always nice to have a normal to compare with. Now we're going to talk about an anterior MI, and straight down the front of the heart, the anterior part of the heart, that's your LAD. Unfortunately, we call that the widowmaker. This is the left anterior descending. And this is what an anterior MI looks like. So pay particular attention here to V3, V4. A lot of times it's anterior septal, so V1, V2. V3, V4 will be involved, and you can see that ST elevation. There's reciprocal changes. So if you think about that heart that we just talked about, the whole anterior part of the heart, what's kind of the opposite end of the anterior part of the heart? Well, it's down here. It's that inferior part. And that's why those inferior leads, 2, 3 AVF, get ST depression. They're doing the opposite. So that's what's going on there. Let's talk about a lateral MI. So again, that left circumflex coming around the side of the heart. What does that look like? Here's the lateral MI. You can see the ST elevation in 1 AVL, V5, and V6. It's a particularly, on this EKG, you can really see it in 1 in AVL. And then, of course, you get that reciprocal depression. What's on the other side of the lateral leads? You can kind of look again at 3 in AVF, maybe, again, that inferior area. Let's talk about an inferior MI. I don't like MIs, but if I have to diagnose one, I like the inferior MI because it's usually very clear on the EKG. You can really tell that someone's having an inferior MI, and you can it's jumping out at us, that ST elevation in 2, 3, and AVF with some reciprocal ST depressions in AVL. Posterior MI, this one can be a little bit tricky. Don't be fooled, because when you initially look at this, you're seeing ST depression, right? You're seeing the ST depression, and you might not think this is a STEMI, but you have to remember that this is a posterior MI. So if you flip that EKG upside down, it looks like ST elevations. And really what you're looking at here is the R wave in V1 and V2 compared with that S wave. That R wave is tall. Very tall. And you have an upright T wave. That is kind of a tip-off. You've got this really tall R wave compared with the S wave, and you have significant ST depression in V1 through V4. In this case, you can't see it quite as much in V4. That is your posterior MI. And when you flip that EKG upside down, hold it up to the light, again, you can see the ST elevation. Instead of going to the right, you'll see it, you can see here it's going to the left because they flipped this EKG. This is with posterior leads added. You do not have to get posterior leads. You can diagnose a posterior MI without the posterior leads, but they can be a little bit helpful in just confirming your diagnosis. But be warned that if you get posterior leads, which is really just extending the EKG around to the back and then having them run it again, and you can see here V7, V8, V9 is showing that ST elevation. Those are now our posterior leads. Be warned that if you don't see ST elevation in the posterior leads, and all you saw was deep ST depressions anteriorly, that can still be a posterior MI. So getting posterior leads and not seeing a change, you can still have a posterior MI, okay? So it's like you don't need that for confirmation of the posterior MI. That's the big takeaway. The last thing I want to talk about are STEMI equivalents, and some things have changed here. So these are equivalents in our mind, things we should really worry about, where you want to get cardiology on the phone, you may be pushing for this patient to go to the cath lab. You should be concerned about your patient if you're seeing any of these. Posterior STEMI, hyperacute T waves, we call those de Winter T waves. Now, in the past, the AHA only recognized one of these as a STEMI equivalent, and that was a left bundle branch block with original Scarbosa criteria. And I just want you guys to cross out that last bullet point because this changed in October. In October, they changed this, and now they do recognize de Winter T waves as a STEMI equivalent, and they also recognize a left bundle branch block with modified Scarbosa criteria. Those are now STEMI equivalents, as well as pacemakers. It has to be a right ventricle pacemaker, but pacemakers meeting modified Scarbosa criteria meets STEMI equivalent. Those are new guidelines as of October. Just remind yourself what these look like, the de Winter T waves. They're just tall T waves, prominent T waves. They're in the precordial leads. They also have an ST depression, a smiling ST depression at the J point. It's like an upsloping ST depression going into a big T wave. The modified Scarbosa criteria, just remind yourself about that because I'm out of time. Number one, there's 3 of them. Number 1 and number 2 are exactly the same as the original Scarbosa criteria. It is just the 3rd one that's different. That's what makes it modified. And essentially it says if you have discordant, so if the QRS is going down and you have ST elevation, so discordant leads, basically QRS down, ST elevation going up, you have to have that, and then the ST elevation. In the past, remember they said it had to be more than 5 millimeters. That was the original Scarbosa criteria. The modified now says it's relative. So it needs to be greater than or equal to 25% of the depth of that QRS. The QRS going down, ST elevation, greater than 25% the height of that down-sloping QRS. That's the modified Scarbosa criteria. And ST elevation in AVR with diffuse ST depressions. That is concerning for an LAD occlusion. That is something we're worried about as being a STEMI equivalent, not officially recognized. There was one other one that I wanted to mention that I cannot remember off the top of my head. I'm going to look it up. I'm going to put it in the chat. There was one other one that was also concerning that we should keep in our minds, but those are the big ones. And, oh, I'm sorry, I'm going over, you're here now. Okay, great. The last thing I want to say is about chest pain risk stratification and sort of how do we risk stratify. Remember to use your heart score. That's the big thing. Use your heart score. Find out if that person is low risk or moderate risk. And the new guidelines, these are the updated guidelines, essentially say if that patient is low risk, so less than or equal to 3 on their heart score, they do not need urgent follow-up. That means in the next 30 days, they don't need any extra testing, such as a CCTA, a coronary CTA, or a stress test in the next 30 days. You've got like 30 days to play with if they're low risk. Whereas, remember before, we were like, you got to get follow-up within 48 hours. Now, they're saying low risk, no, you don't need emergent or urgent follow-up in the next 30 days. They're good. For moderate risk patients, you just kind of risk stratify and engage in shared decision-making. Moderate, intermediate risk chest pain patients, they may benefit from imaging, like a coronary CTA or a stress test, sort of depending on their age and risk factors, and you can engage in shared decision-making with them about that. They don't all need to be admitted if you can get them close follow-up. Just remember, women and young people do have MIs. They do present differently. There's bias in our care, especially with women, elderly, diverse patients. Keep that in mind. People may not present classically. A GI cocktail, even if that patient has relief, does not exclude ACS. Keep in mind red flag risk factors, which are listed here. And that's it. Thank you all so much.